Okay, folks, welcome to the review session of the upcoming exam, test number 3, which will cover chapters 13, 14, 15, 16, 17, and 18. Lots of chapters, but luckily they are all review. So let's get started. We can have questions and answers at the end. I believe I started the recording, so that's good for me. The dental medical history is one of the first things that you collect. Hopefully you have an indication prior to the patient even sitting down in the chair, because they've either pre-filled it out and you've got the paper work, or they have filled out the medical history and it's miraculously appears in a portal for the new patient coming into your private practice or however your office does it. But you've got usually have it before you even see the patient. So that's one of the first things you have, and we really can't do anything with the patient until we have a thorough medical and dental history, okay? Because we need to know who is sitting in our chair and what complications might arise because of that. Now, again, medical histories are subjective data. The patient will decide whether or not they wish to disclose things to you. And a lot of times we're just here to get our teeth cleaned, and you don't need to know about this or that or my heart attack or whatever medications I'm on, because it has nothing to do with my teeth. And so our role again is to let the patient know we need to know everything you're taking, not just medications. So one of the courses I took last week was asking not what medications are you taking, but what are you taking? Are you putting anything in your mouth in the form of a pill or an herbal, regardless of what it's for? So we need this information. The medical dental history consists of a personal profile, a social history that lets us know what's going on with the patient, the chief complaint, why are you here? On the templates, we always have after medical history, we've got chief complaint, CC, or C-O is another way to say it, or complains of. A lot of times they'll just be, I'm here for a cleaning. A history of the present illness, as well as the family history, because we want to see what's going on with their propensity towards acquiring something. So there are a number of ways we can do the medical history. One of them is the interview process, and that really is critical to the success of thorough medical and dental history taking. We want to make sure that we're asking open-ended questions. They can have a yes/no history in front of them, but it is our job to then follow up with questions. So it can be a questionnaire, it can be a patient interview, or ideally it's both. That way you're able to do some personal follow-up. So the personal profile consists of the name, the age, the address, the occupation, telephone numbers, how do we reach the patient, as well as the physician's name and telephone number. A lot of times patients won't have that with them. So what do? We ask them to please bring it next time, because we need the physician's name and number, as well as an emergency contact in case something does happen in the chair. The social history includes their occupation, their lifestyle, what is their family and social structure, which can give you an insight into their attitudes on where their oral health and physical health lie in their scheme of importance, what their marital status is. Their diet oftentimes will go along with the Canberra or the Caries risk assessment. Alcohol use, how often and how much. Tobacco use of any kind, even vaping. We want to know how much, how long, and when. Is it just social on the weekends? Well, if it's social on the weekends and they're spending their entire weekend at a hookah place, then they're getting a lot of damage. So we want to try and do that as well as report things in pack years. Now, group 4 did a wonderful job of explaining what pack years is as well as the textbook, so you need to know what the pack years is. Chief complaint, patient needs to state in their own words. You're putting quotations. Why are you here today? Pain, no matter what their chief complaint is, I'm here for whitening. I don't like the way this front tooth looks, whatever. If they're in pain, the pain has to be treated first, all right? We are not negating what the chief complaint is, which is whitening or whatever it is, but we have to help the patient understand why we are prioritizing certain things, that this has to be done first, then we can address your chief complaint. Signs of periodontal disease, okay, for their chief complaint. Do they have bleeding gums? Do they have bad breath? Or has anybody complained that they have bad breath? Are there any mobile teeth? The symptoms, those are the signs. The symptoms the patient can be experiencing could be saying they have pressure in their gums or pressure in their jaw. A lot of times they'll say they have itchy gingiva, and when you're scaling, it really feels good to them because you're finally reaching something that itches. Don't understand that when it comes to gingiva, but boy, the middle of the back that I can't reach, it does feel good, doesn't it? So what is the history of their present illness? Okay, the patient's awareness of the problem is something that we are assessing. We are asking about previous treatment. Has the problem occurred before? How long has it been going on? What was the onset? What was the cause, if they know? The location, oftentimes, where is it? As well as their duration. So think about any illness that the patient has that they say yes to. Arthritis. A follow-up question, wouldn't you want to know, where is their arthritis located? Is it in their neck? Can I lay you down? Is it in your hands? Does it prohibit you from grasping a toothbrush adequately or using dental floss with your fingers? These are questions that we're trying to answer when we're doing these questionnaires. So the medical history is a legal document. It must be signed and dated by the patient as well as the dentist. For us, it's the clinical faculty that is signing it, but it has to also be signed by somebody of legal age. So that means if an interpreter is there, hopefully they are over 18. If it's a child that's younger than 18, we have to make explicit notes saying this was translated via whoever, age 12, whatever it is. It's not ideal, but we want to really document everything. It needs to be updated at each and every visit and signed again. So yes, that means if you have a Tuesday morning clinic, the patient's dismissed for a little while for lunch, and then a Tuesday afternoon clinic, you are updating the medical history and vital signs all over again. Now, that does not mean that you are going through all the questions. Have there been any changes from this morning? Have you taken anything since this morning? Because sometimes they'll be taking ibuprofen or a sinus pill or something. So you just want to document that. It only takes a couple of minutes along with their vital signs. Then you get that checked, and then you go on to the EOIO for the afternoon as well. But you're looking for current and past statuses of the patient's general health. So again, it can be a little bit of everything. A lot of offices will send out things beforehand and have the patient. In the old days, they'll bring the medical history in with them, or they will sit out in the reception room, fill out all the new patient forms as well as the medical history. But a lot of offices have gone electronic. And we only really need to record the relevant facts and details, okay? The medications, for example, something that needs to be highlighted, because the medical history is always the original medical history that's being saved. We never touch that after it's been signed. We want to know what their current medications are, including over-the-counter, especially herbals, if they're taking them on a daily basis. We're looking for drug interactions. We're also asking them about drug allergies. For the medications, we need to know the name, the dosage, the frequency, and why are they taking that. That all needs to be written down. There are so many medications that are being taken for other things than what they were originally designed for. So we can't guess why the patient's taking them. Plus, it lets us know if the patient knows why they're taking them. Well, the blue pill, I think, is my water pill. I'm not sure why I'm taking it. But there are a lot of medications that have multiple uses. So that's why in parentheses, we're putting why the patient's taking it. That's our little cheat note too. We don't know all the medications. There's so many out there. So we're looking for drug to drug or drug food interactions. And that's where looking up these medications on the Lexicomp site can really be beneficial, or looking at the pre-made cards if you've purchased those, because if they're taking an antidepressive and they're also taking St. John's wort, you need to be counseling the patient. Okay, if they are on a blood thinner but also eating a lot of broccoli or spinach, they need to be counseled, because there will be some interactions with that. So the more you look at these and have to look them up, the more they will be in your memory. In private practice, do we expect you to be looking up medications? Heaven, no. But you can ask the patient. I do that all the time. I'm not familiar with this medication. What can you tell me about it? Do you mind sharing some information? You're looking for adverse side effects. What is one of the main adverse side effects for a lot of these medications? You never know. Just put xerostomia. You know, you're 75% correct if you choose that one. As well as hypotension. Some of them will lower a blood pressure. So you do want to know what the adverse side effects are. And if you have questions, it will arise at this time to see if the patient needs any alterations. Do they need an INR for this medication that they're taking, for a blood thinner, or is it one of the newer ones where they don't need an INR? We need an INR, we need a medical consult if the patient doesn't know what it is. So again, we need to know as much as we can about the medication. We also are looking for conditions that can affect the periodontal health. Diabetes, leukemia, HIV, AIDS. If the patient's medically compromised, do we need a consult with the physician? Now, while you're in school, if a woman comes in pregnant, we need a medical consult. In private practice, they don't need a medical consult unless they're at high risk or something, but it's very rare that a patient who's pregnant, for example, will need a medical consult. School is very conservative and a learning institution, so we have different rules than what private practice has. Is the patient at risk for infective endocarditis? And that's an infection of the tissues in the lining of the heart. So some dental procedures, mostly all dental procedures that cause bleeding, can allow the bacteria that's in the mouth go into the bloodstream, resulting in a bacteremia, which can result in infective endocarditis. So antibiotic prophylaxis may be needed for certain heart conditions. So we have to follow the American Heart Association guidelines. Even if the patient comes in and says, I had a stent put in or a hip replacement or something 2 months ago, my doctor said I don't need to worry about it. American Heart Association has guidelines for it needs to be 6 months out, blah, blah, blah. We need to have a follow-up with that. So this is your license that you're working on in private practice. So it's important that you know what parameters you are allowed to work under without getting into trouble. What's the family history? Their present and past medical illnesses of family members can let you know if they are predisposed to any conditions, but it can also help you identify other risk factors. Interleukin-1 genotype, think of that. What's their dental history? Their experiences with local anesthetic as well as nitrous oxide. Have they used it before, especially if your office has nitrous available? Some offices don't even have it. And that includes past and present. Dental treatments, did you have any problems? Did you have any bleeding problems? What are their oral habits? You're taking some nutritional profile that's in with the caries risk as well. And what was their response to treatment, their oral hygiene status? Are they following up with recommended care? What is their, what we call dental IQ on their hierarchy of needs? So medical history also has to do with the vital signs that you're taking, and you will be following the clinical protocol for if they've got an elevated blood pressure or whatever. Okay, so keep that handy. Any questions on medical history before we move forward? We're moving forward. All right, the EOIO, extraoral, intraoral exam and dental evaluation. This occurs after completing the patient history. Sometimes it's more of a limited exam. The patient's coming in with a hot tooth, it's painful, it wakes them up at night, and your job is to do a medical history review and to get a radiograph of that area. So for that, you need a limited oral exam, and not necessarily the EOIO like we do in school. I have always done them like we do in school. Do I make my notes like we do in school? Heck no. Linea alba, Fordyce granules, those type of things, we don't mark down in the real world. We're marking them down in school because we want to see that your eye is noting things and you're not just going through the motions. But after the medical history, we're doing a clinical exam that includes the EOIO, a dental evaluation. We're also doing an oral hygiene evaluation, gingival assessment, color, contour, consistency, that type of thing, and a complete periodontal evaluation, which is part of the gingival assessment as well. So for the EOIO, we've got the visual exam, palpation, instrumentation, percussion, an electrical test if needed, and oscillation if needed. So a visual exam is the direct observation, radiographic exam, and transillumination. Palpation is the feeling by the sense of touch. Instrumentation is using examination instruments, your mirror, your explorer or probe. Percussion is striking the part of the body. So we're striking the teeth, tap, tap, tap. An electrical test is a pulp tester. It's putting a mild current through the tooth. The patient's letting us know when they feel something. And it's kind of like a if you can appreciate what that would feel like. And then oscillation is listening to the sounds from the parts of the body with a stethoscope. If you're in a TMJ practice, for example, the hygienist is trained on what to listen for. So they're putting the end of the stethoscope at the TMJ, asking the patient to open and close, listening for the various sounds of crepitus and what they mean. While you're bringing the patient back, you're doing your overall appraisal, their gait. Are they doing the old man or old lady shuffle? Looking at their eyes, are they bright? Are they half closed? Do they look lethargic? The lips, the skin, the head, the neck. Overall assessment. Now this is part of the assessment is your vital signs. It's not part of the medical history, all right? This is part of the assessment, but we're clumping the vitals with the medical history, with how we're getting our checks. EOIO, you're looking at everything. You know how to do this. For the oral cancer screening, yes, we do tell our patients we're doing an oral cancer screening. We do it on everybody. We want the patient to be informed of what we're doing for them, what we're looking for. And that's when you can be using your simpler terms. We're doing an oral cancer exam. Cancer oftentimes will show up in the head and neck area before it will show up in other parts of the body. So we're looking for the lumps and the bumps, or however you want to say it. But let the patient know what you're doing for them. Your dental evaluation is really starting when you're putting the mirror in the patient's mouth before you do your intraoral examination. This is where you're going, oh my gosh, what am I getting myself into? Or, okay, this doesn't look so bad, right? That's your first look. Then you are charting. Oftentimes missing teeth is one of the first things. This is going into the hard tissue charting, existing restorations, everything. That really goes with part of the radiographic assessment, which can be before or after you take, you do your perio assessment, but we can't do a perio assessment without the radiographs. And we're marking down certain things here. It's important before you do your perio charting is to cross out or remove the missing teeth from the dental chart, because you can be one tooth off and when you're doing your perio charting, and it's a mess trying to figure out which tooth you missed. Right, so the number of teeth, you're looking for caries, the restorative status, are they taking care of things that come up? Do they have dental implants? What's their motivation? Are they motivated to take care of things and replace missing teeth? You're looking at occlusion and proximal contacts. You're charting the teeth that are present and the teeth that are missing, what's congenitally missing versus what was extracted. If I'm missing number 7 and 10, you're asking the patient. All right, sometimes in the old days, they were removing those teeth to make room for the canines, and then they were blunting off the incisal edge of the canine to make them cosmetically appear more like laterals. So were they congenitally missing? Are they impacted? You haven't even taken radiographs yet. What's going on with the various teeth? Do they have wisdom teeth? I don't know. They never came in. I had them extracted, or didn't have them extracted. Do you need to take a pan in addition to an FMX for this particular patient? What are their needs? GV Black, you need to know the GV Black system. Yes, the second year students were coming back saying they had questions on the type of restorations or the type of decay for the 1, 2, 3, 4, 5, and 6. So you do need to know GV Black. Most offices use it. Okay, it's described by location. Is it pit and fissure, a smooth surface, interproximal, right? And for the visual, we're looking for a change in color. We're looking at radiographs. There are other diagnostic tools that can fluoresce inside the mouth to show us changes in illumination, to show decalcification, and gives us a rating for that. You're also looking for root caries, right? This leads to an increased biofilm retention. If the root surfaces are exposed, they've got more geography in the mouth to collect, and it's detected by visual inspection by a blunt instrument. You don't want to go poking into a little brown area or an area that looks leathery right below the CEJ. Sometimes it's hidden because it's underneath the gum tissue, which is not as common as something that's super gingival. So what are the risk factors for root caries? Gingival recession, dry mouth, head and neck irradiation. Yes, advanced age oftentimes comes dry mouth and lack of dexterity to be able to thoroughly clean like we used to, as well as we're going towards a softer diet, depending on what the medical situations are. These root surfaces have not had the benefit of lifelong fluoride. They only have the benefit of fluoride from the time that root surface was exposed. So they are very much behind the curve on getting that fluoride protection. Are they smoking? Are they in good or poor health? What is their pH in their mouth? We're going to be starting to be doing more chairside tests for our patients. And I really see that pH is going to be one of them. pH as well as buffering agents in the saliva, because it's something we can do very simply for our patients. And if they have an acidic saliva to begin with, and they have recession on top of it, it's a recipe for root caries. What is their restorative status? You're looking at those things. Do they have implants? I took a course last night. This is how nerdy I am. I was sitting in front of a computer taking a Colgate CE on implants. And they did reiterate the survival rates are good if periodontal maintenance is maintained, is well maintained. So the patients who were going in every 3 months kept their implants longer than the patients who weren't. And mainly it was because you could detect something going on earlier instead of waiting. Malpositioned and proximal contact relationships is part of your occlusal as well as your periodontal assessment. You're taking the floss and placing it between the teeth, looking for open contacts. You're looking for crowding. Where things are out of alignment, are they having any compromised oral hygiene because of it? Do they have inflammation? Is it a food trap? Or is food just pounding in there? Okay. Crowding teeth doesn't cause gingival harm by itself, but it can set up a scenario to create gingival harm. Missing teeth, are they getting them replaced? If they're not, are things shifting, right? What are their marginal ridges? Is one tooth up higher than another tooth that's down lower? Those are those marginal ridges. Those are more prone to having food traps. Open contacts, again, we're looking with them for them with dental floss. The thing that the course said last night, which we'll be getting into in the implant chapter also, when implants first started back in the 60s in Europe with Brennemark, they were doing the initial studies and the longevity of implants on fully edentulous mouths. We are now doing one implant here or one implant there or two implants, but we're doing it with mixed dentition with partially edentulous teeth, and that sets up a whole different scenario for the patient and their bite and everything else. But if an implant is next to a natural tooth, over time, just by virtue of how the bone reacts, it will become an open contact. So either on the mesial or the distal. So that's something that you need to be looking for, because if it's creating an unhealthy situation, then a restoration might need to be placed on the mesial or distal of the natural tooth to close that up. You're looking for tooth wear, attrition, tooth-to-tooth contact. Patient might not be aware of what their habits are doing. Abrasion, right? You're looking at the CEJ areas and for any recession. Erosion is the chemical wearing away. Where is the erosion? Is it on the linguals? Is it on the linguals of the posterior teeth? Maybe they have acid reflux. Is it on the linguals of the maxillary teeth? Maybe they're vomiting. So you can be the detective that way. And abfractions, which are non-carious dental lesions, and they're wedge-shaped, and it's usually due to the flexure of the tooth. Intraoral appliances. Ortho. Think about all the geography and added surface areas that biofilm can have. Do they have retainers? Do they have splinting wires? Do they have challenges on taking care of their teeth, right? These all make cleansing difficult, so we have to be aware of this and come up with some creative ideas on what the patient can do, right? Because just by virtue of having some of this stuck in their mouth, there can be edema. There can also be gingival overgrowth, even though they're not taking those medications that we're aware of. We're looking at tooth stain. Is it chromogenic bacteria? Is it from foods? Is it from chemicals? Is it endogenous? Is it within the tooth structure and can't be removed by polishing? Is it what we call a quote unquote dead tooth because the nerve has died, so it's got that grayish? Or is it a green stain that's become impregnated into the tooth itself because of decalcification? Intrinsic stain can come from non-vital teeth. It can also be evidence in deep caries or root canal treatment. Dentin exposure will give the tooth the yellowish brown versus a non-vital tooth is more of a blackish red or a bluish black. Excessive fluoride are your white opaque spots down to a brownish. And that's usually occurs between the 3rd month of pregnancy and the patient being 8 years of age. So we're holding off on prescribing tetracycline-based medications during that time. Tetracycline, minocycline is kind of a grayish brown. And if that's given during the 2nd trimester of pregnancy through 8 years of age, then this again can be in the fetus. But the minocycline can also be showing up through the gingiva of adults. And the gingiva will appear a little gray because the bone underneath the gingiva is picking up the stain as well. Extrinsic stain, know what they are, what they're caused from. The lesson is you want to remove as much stain as possible with your scalers, gently scaling in OHE, okay, first to get the biofilm off before you start scraping away. Okay, so it's OHE first, then gentle scaling because you don't know what's underneath. Are there white spot lesions underneath this biofilm? You don't know. Coffee and tea, oftentimes not, but that's a black to a brown stain. Chewing tobacco, some patients will stain heavily and some won't, but boy, this is thick, leathery stuff that can come off for chewing tobacco and smoking tobacco from the tar products. And it smells like tobacco when you're scaling it. Chlorhexidine is a yellow-brown stain, usually along the gingival margin and going interproximally. Black line stain, do you remember who is more prone to black line stain from your dental hygiene course? It's usually women who have fairly good oral hygiene. Okay, it's gram-positive rods. It needs to be scaled off. This stuff does not polish off, but it's calculus-like. And then green stain is chromogenic bacteria. What's the significance of stains? It can indicate rough surfaces. It could indicate areas of biofilm retention because the bristles of the toothbrush aren't scrubbing that area well. So especially if there's crowding, for example, on the mandibular anteriors, those linguals where the tooth is more forward, coming more labial verted, might not be able to get the friction of the toothbrushes. So we need to take a look at the stain and document appropriately and take the appropriate action. So again, the first course of treatment is not getting your coarse pumice out and polishing it off. Dentinal hypersensitivity is a painful response to an irritation where roots are exposed. It can be transient, but it's a sharp pain. It's not long lasting. You know, this is the one where the patient puts their fingernail right there on the gum, and you can't see me, but I got my fingernail in my mouth, and it only hurts when I do this, right? So we say, well, then stop doing it. But it can vary in intensity, and it can be transient to the point where, and also they can't pinpoint it. It's just someplace on that maxillary right quadrant. They don't know which tooth. Dentinal hypersensitivity can be a result of vigorous toothbrushing, tooth whitening products where the peroxide is interfering with that fluid balance in the enamel rods. Thermal stimulus, hot and cold. Mechanical periodontal debridement, that's us. They've got this nice barrier of calculus around the tooth. It's great. And then what do we do when the patient's there? We take that whole ledge of calculus off, exposing that root surface. You can bet they're going to be sensitive. So you want to predict that and give the patient some desensitizing toothpaste with stannous fluoride and or potassium nitrate in it, and have them start brushing with that. Periodontal surgery. Think about it. The gums used to be at the CEJ. They've whacked them all off and reshaped the bone, and that gum is now 4 millimeters below the CEJ. Those are newly exposed root surfaces, and yes, my friends, they will be sensitive. So right now, the theory is called the hydrodynamic theory for hypersensitivity, and that's saying that the fluid in the exposed dentinal tubules contracts or expands when external stimulus is applied. That is causing the pain. So that occurs in areas where there's gingival recession to the exposed dentin. Think about those patients that don't have the enamel and the cementum meeting. Those are patients, their gum tissue might not be recessed at all, but boy, do they feel it when you're just trying to go in with some air or the periodontal probe. So we can do pre-treatment sensitivity testing and pre-treatment treatments for our patients. Sometimes it's having them brush with something like Sensodyne 2 weeks before their appointment. You know, they get rid of their toothpaste, they use this exclusively for 2 weeks. We have the Tom's of Maine toothpaste that has arginine in it, and arginine is a very effective desensitizer. So you can polish with that prior to your scaling. And there's other things as well that we'll be learning about as you go through. Any questions on that so far, on chapter 14? Okay. We're going straight into chapter 15, the clinical exam, gingival assessment. This is always telling us what the patient has today and what has happened in the past. So we're looking for the health or disease state with how the patient's presenting themselves today and what's gone on in the past. We don't know if it's ongoing or not. So the purpose is to evaluate the condition of the gingival tissues and to determine inflammatory and non-inflammatory changes. And it's essential in identifying inflammatory periodontal disease as well as formulating the treatment plan. What do you need to do for this patient? Okay, what does the patient need to do? Also, because it's a two-way street. What are some of the risk factors for gingival diseases? They include poor oral hygiene, changes in hormonal levels, certain systemic diseases, the eruption of permanent teeth. When you've got loose teeth, they hurt when you brush, and when you've got newly erupting permanent teeth, they're at a very low level at the gingival margin. So you've got high teeth and low teeth, they're all over the place, and certain medications that may encourage dry mouth or gingival overgrowth. But you're looking at the interdental papilla and the gingival margin because those are the first areas that are affected by inflammation. It's usually the papilla. The cardinal signs of inflammation: redness, swelling, heat, and pain, as well as loss of function. But loss of function might not be present until advanced stages of periodontal disease when the tooth is so loose they can't chew with it, right? Periodontal disease, like blood pressure, is one of those silent diseases. Patients don't know they have it until it's usually at the advanced stage. So we're really zeroing in on descriptors of health versus disease. We're looking at the color, contour, consistency, surface texture, the size. Papillas, are they long and narrow? Are they short and fat? You know, it can make a difference, okay, in your description as far as what they look like on paper, so to speak, or in the computer. So for color, we're looking at a pink to coral pink due to the amount of keratin in the epithelium as well as pigmentation. The color is determined by the degree of vascularity. Okay, think about it. If you're very vascular and have thin gum tissue, you're going to be redder than if you've got thick keratinized epithelial tissue. It's going to be more of a pale pink. The presence of melanin and as well as the thickness of the epithelium. In perio, there are grades where you determine how thick is that epithelium, because if you're a thin gummed person, you have more of a chance of having recession than if you're a thick gummed person. And it also lets the periodontist know, if you're a thin gummed person, that where they might need to be taking their donor sites from. But tissue redness is not the only thing that we're looking for. We're looking for color, we're looking for size, okay? We're looking at, is this an amalgam tattoo or is it cancer? And you've seen pictures of that. We're looking at the contour. The shape and position of the teeth are going to determine what that papillary interdental area looks like, okay? Or is there clefting there? But changes may reflect past periodontal destruction. And think about also the contact areas. The anterior teeth are going to have longer narrower papillas versus the posterior teeth. Marginal gingiva, okay, it's the landmark for the entrance or the crevice. It's a knife edge that shows us health when we say it's knife edged. It can become rolled or rounded with disease while it becomes fluid filled. The interdental papilla, what's the shape of it? The papilla may also be cratered or blunted, so you're classifying your papillas in your perio assessment as well. Are they type 1, 2, or 3? Is it generalized or localized for these things? You're looking for gingival clefts, which are those V-shaped slits. They can be caused from improper brushing, improper flossing, or a result of pocket formation. Now, a pseudocleft is something that occurs when the adjacent papilla becomes enlarged to the point where they join each other at the center of the tooth. So think about mandibular anterior teeth that are crowded and with inflammation. All right, you've got one big bulbous papilla next to another big bulbous papilla. They're so big that they're touching each other and it looks like a big split. Okay, so that is what a pseudocleft is. You're looking at consistency, and that's examined by lightly pressing the side of the probe against the marginal and interdental papilla. Is it keeping a indentation there? Okay, and that refers to the firmness of the underlying connective tissue. Edema may cause pitting as well as gingival enlargement. Fibrotic tissue is very firm and resilient, but again, it's not healthy. It's hyperkeratinized because the collagen fibers are destroyed. It's thick, it's leathery. What is that surface texture? Okay, does it have stippling? Is it glossy, right? Stippling, again, may be present in health or disease, right? Especially if the disease tissue is fibrotic, chronic inflammation. What's the size of the gingiva? It's influenced by cellular and intercellular elements in the vascular supply. Where is it in relation to the tooth? Is it above the CEJ or below the CEJ? Now, the board reviews always talk about hereditary gingival fibrostomatosis. I don't know why, but they still do. Nobody's really ever seen it except in books, but it's a form of severe gingival enlargement that's seen in children, and that's when it literally covers the entire tooth, including the incisive and occlusal surfaces. Pregnancy gingivitis occurs with a hyperreaction of the gingiva to the hormonal changes. All right, it generally doesn't occur with good plaque control or good oral hygiene. It may with gingivitis, but the pregnancy tumor is another thing. That's the pyogenic granuloma, is an inflammatory reaction to the biofilm. Then you've got your puberty gingivitis, which occurs in adolescence, and your menopausal gingivitis, which occurs in the older women. And again, it is hormonal gingivitis. Drug-influenced gingivitis is caused by certain medications, so know those. We've gone over them a number of times. Gingival bleeding is accepted as an objective clinical sign of inflammation, but it doesn't necessarily indicate disease activity. It can mean inflammation, but it doesn't mean further breakdown. So bleeding on probing indicates inflammation. Bleeding occurs when there's a disruption of the sulcular or junctional epithelium because of the micro-ulcerations. And if you're a smoker, or our smokers tend to exhibit less gingival bleeding because things are thickened and fibrotic. They're more leathery. Any questions on chapter 15? Let's go. Yeah.
Oh, no, I was just saying that.
Oh, okay. All right. Chapter 16, clinical exam. The periodontal assessment requires a mouth mirror, periodontal probe, and radiographs. So this includes, again, you're not doing this until you've got your medical and dental histories, your gingival findings, Okay, you have your probing depth, your CAL, clinical attachment level, or is it lost? Mobility, malposition teeth, their level of oral hygiene and occlusion is in there, as well as a description of the bone level. Right, so periodontal disease is episodic and can be recurrent. But when you have a patient, as a new patient, you are seeing them for the first time. You don't know what their history is. So that's just providing you a baseline for where are they today. And that is letting you know what the past disease history is. So it's used also to see what's going on in the past, but also what is our outcome measurement. Did we have successive treatment? Are these areas or our goals that we've established for our patient and that they've established met? So your goal might be for your self-eval to decrease the plaque index to by 10%. Doesn't always have to be to under 10%. That's what we want. But if you're starting out with a 100% plaque index or biofilm index, then maybe 10% is more realistic for that particular patient. And then when you redisclose, did they meet that goal or not? But 50 to 75% of the adult population is affected by some sort of periodontal disease, and that includes gingivitis. So we are responsible really for monitoring periodontal disease, and hygienists that are sued or get in trouble, it's usually for lack of diagnosing as well as informing the dentist and the patient of the periodontal status. That's what we get in trouble for more than anything. So periodontal disease usually occurs in adults. We can see it in younger people for the aggressive forms. So it's important that we do some sort of assessment on everybody, right? So that's one reason why even on pedo patients, we're doing gingival margin and mucogingival line. We're just getting used to looking at them, okay? But it represents the total destruction as well as healing that can occur during the lifetime of the tooth. So we determine that by visual inspection, by our measurements, and by evaluating radiographs for bone loss. Now, periodontal disease activity, right? Now, this is from the textbook, right? Current and ongoing loss of soft tissue attachment, destruction of gingival fibers, and apical migration of the junctional epithelium with subsequent alveolar bone loss. So if they have periodontal disease activity, they are still experiencing bone loss. You have a 5 millimeter or a 7 millimeter last year, a 7 millimeter 4 months ago, and a 7 millimeter today. They don't necessarily have disease activity. They have infection, but they need to have that 2 millimeter destruction in order for it to be considered active bone loss, right? So it's episodic periods of exacerbation or active periodontal tissue destruction and intervening periods of disease inactivity. We don't know how long that inactivity is going to be where that patient's stable. So we're probing. It lets us know what's already happened. We're looking at radiographs. It lets us know what's already happened. And those are different from periodontal disease activity. So the pockets are a result of the destruction of the coronal part of the junctional epithelium and the connective tissue attachment to the tooth surface at the apical aspect of the junctional epithelium. Now that JE is only how many cells thick. We're only talking a couple cells here. But the primary purpose of probing is to determine the extent of detachment of the junctional epithelium from the tooth surface. So, probing depth is defined as the distance from the gingival margin to the most apical extent of the probe where resistance is met. So that's the coronal portion of the junctional epithelium. Can you visualize that? There are some limitations to probing. We are penetrating the tissue. What force are we using? Okay, heavy-handed hygienists or clinicians are going to get about 1 millimeter deeper than not heavy-handed. What's the size of the probe? Is it chunky or is it real thin? All right, because the thinner one is going to probe deeper than the big chunky one. What's your placement and angulation? What type of probe are you using, and what's the tooth anatomy? Can you maneuver around that tooth anatomy? So one of the things we're doing is we're figuring out the clinical attachment level, or CAL, and that's the distance from the CEJ to the most apical extent of the periodontal probe where resistance is met. So the CAL is a clinical approximation of the loss of connective tissue, okay, from the root surface, or the level of connective tissue, because if there's no attachment loss, it's a clinical attachment level, it's not clinical attachment loss. How's that for making things confusing? But the CEJ is considered the stable reference, so that's what you're always going on, and not the free gingival margin, because that free gingival margin can move, apical or coronal. So the significant increase in the clinical attachment level is the gold standard for the measurement of periodontal disease activity, or a site that's actively losing connective tissue attachment at a given site. So a change in the attachment level between 2 and 3 millimeters measured at different examination sites needs to occur before the site is labeled disease active. Okay, that means they've got attachment loss. So it's got to be at least 2 millimeters, up to 3, because we give ourselves that plus or minus 1 millimeter each time we probe, from your probing to your probing again to your probing, or me going in and probing. Okay, that plus or minus 1 millimeter, it's got to be beyond that for it to be considered active. There are controlled force probes out there, which has a fixed 20 to 25 probing force. Now 25 is getting into be pretty heavy-handed there, because we want 10 to 20 ideally. And that is automated. The periodontal screening and recording, board questions are on. Okay, that's a PSR. It was developed by the World Health Organization as a quick way to screen a lot of patients. It indicates when a more comprehensive exam should be performed, because the whole thing only takes about 2 to 3 minutes. You're probing everything. You're not writing everything down. You're just writing down one number for each sextant. One number, and that number will tell you where they are on the scheme of health. Okay, but there's a little ball at the end of the periodontal probe, and the numbers are 1 through 4. And it will tell you if you've got a 1 and a 2, they're within normal limits when it comes to probing depth, but you can also have an asterisk or something to denote bleeding or a rough surface. 3s and 4s say you need to go in and do a comprehensive full perio exam. So that was adopted by the AAP and ADA some years ago, back in the early 90s, I believe, because again, we'd rather you have a PSR than nothing at all on your patient. Okay, it was a way to try and get us in with the periodontal probe. Connective tissue attachment loss. The attachment loss is the pathological detachment of the gingival collagen fibers from the root surface with the apical migration of the junctional epithelium. Standard definition. So a change in the CAL between 2 to 3 millimeters needs to occur before the site is labeled disease active. Said that a couple times here. Probing depths. Okay, when we're doing probing, we're taking 6 measurements when we can around each tooth. I know some of you have had instances with partially erupted third molars or whatever. You can't get to the distal buccal or distal lingual of a surface. Well, you're not going to have all 6 measurements there if the tooth is partially erupted. Most errors occur interproximally, okay, because that has to do with how we're angling the probe. When probing posterior interproximal areas, the probe should be angled slightly so that the tip of the probe reaches the caul area. And again, those caul areas need to be overlapped from the buccal and the lingual. You can have what we call a pseudo pocket, which is above 3 millimeters, but it's not really a pocket, and it can be completely healthy. I have 5 to 6 millimeters on the distal of 18 and 31. I had no third molars, so my retromolar pad is literally on the occlusal or at the occlusal level. So I have a pseudo pocket there, and as long as they're maintained and not bleeding, I don't need them whacked off with the Whitman's procedure, which we're going to get into pretty soon. Don't need to whack them off. But you are always looking at the BOP, the bleeding on probing, that can indicate inflammation in the deeper tissues. Bleeding when stroking the gingival crevice can indicate gingivitis, and it's due to those micro ulcerations in the epithelium. So this only tells us that there's inflammation. It doesn't tell us there's disease activity, right? It doesn't tell us there's breakdown, just that there's inflammation, right? So let's talk just a little bit about the CAL again, the clinical attachment level. This is something that you'll be doing manually while you're in school. If gingival recession is present, again, you're looking at the CEJ as your stable point. You're taking the amount of gingival recession and adding that to the probing depth. If there's gingival overgrowth, right, you're taking that where that CEJ is and you're measuring it and you're subtracting that to where the CEJ is. And so that is a subtraction. And if the CEJ is right about where the gingival margin is or right above, it's going to be equal to the probing depth. So CAL versus periodontal pockets in the millimeters. Review that, okay? This is paramount on what we do. So probing depth of 3 millimeters, and you've got 1 millimeter of recession. Do you add or subtract? This is one where you add. So 3 millimeters for the probing depth and 1 millimeter of recession says that the CAL is 4 millimeters. We've seen these pictures before. You're adding the recession to the probing depth. The shift in the gingival margin apical to the CEJ, okay, that's recession. Can be localized or generalized. And again, that CEJ is your fixed point. Causes of gingival recession. Got a whole slew of them here. Look at the bottom one. Occlusal trauma has been suggested to cause gingival recession, but it has not been proven. So some feel it is, some feel it isn't. Again, it's occlusal trauma in the presence of inflammation we know will cause recession, but does occlusal trauma alone do it? It hasn't been proven, but many dentists feel that it is, so they're recommending occlusal guards or night guards for their patients on the chance that, who knows, 5 years from now or 10 years from now, we might find out that there definitely is a correlation. So they're erring on the side of caution. Gingival recession exposes newly exposed root surfaces, which can make it hypersensitive, which can make it more susceptible to root surface decay. Remember that critical pH for root surface is almost neutral. What is it? 6.5, 6.7, something like that. You're looking at mucogingival involvement. Now, it can be caused from recession or due to recession, and sometimes the gingival margin is right where it's supposed to be, but they have a high frenum attachment or something. So when the probing depth extends beyond the mucogingival junction or is at the mucogingival junction, we call that a mucogingival involvement when there's 1 millimeter or less of attachment. And remember that picture that was on in your oral anatomy lab practicum. Delayed passive eruption. Okay, those are with the patients that have the gummy smile. The CEJ is still buried underneath the gum tissue, and the cervical bulge is not exposed, right? So they might need a gingivectomy for that. Suppuration, is there any pus or purulent exudate? That can indicate an ongoing infection, but it doesn't indicate disease activity, current disease activity. I have put, for the BANA testing, I have put these strips in and tested it to see if they have any red complex bacteria and all this other stuff, and it comes out negative. All right, there's no collagenase present, and it's mind-boggling. How can you have pus and not have disease activity. Very different from infection. Tooth mobility, physiologic, okay, or pathologic tooth mobility. What's the difference? Physiologic tooth mobility is a tooth that is, it has normal periodontium versus, and then undue or heavy bite associated with it, versus pathologic mobility doesn't have a sound periodontium. So even normal occlusion will make the tooth more mobile. Fremitus we're looking at with our index finger, the patient's tap, tap, tapping on the front teeth. So we're looking at that. We're looking at tooth migration, if there's any missing teeth, or if there's periodontal disease. Teeth migration, think about an open bite with the anterior teeth. Miller's classification of mobility, 1, 2, and 3. And I apologize for my typo. Other contributing factors may include tongue thrusting, bruxism, teeth adjacent to edentulous areas, or tooth migration. You're looking at furcation involvement. When you first get your neighbor's probe out, call us. We were more than happy to show you how it works. Again, the neighbor's probe is used to measure the horizontal pattern of bone loss. It's going into the roof of the furcation, the crotch of the tooth, all right, versus the periodontal probe measures the vertical pattern of bone loss. And we use the Glickman classification of 1, 2, 3, and then 4. So again, the horizontal bone loss is going into the crotch of the tooth or the roof. Okay, that's with your neighbor's probe. How far does it go? And then the vertical is what you're using your regular periodontal probe for. Cervical enamel projections creates a plaque trap. Attachment cannot happen on enamel. Palatal gingival grooves, especially the maxillary linguals of the maxillary lateral incisors. Take a look at a couple questions. The purpose of performing a gingival assessment is to evaluate the condition of the dentition. True or false? An accurate recording of the initial findings is essential in forming a treatment plan. So type it in the text box. Fine, nobody's typing in. Okay. Worried I'm going to be wrong. Oh, good grief. Okay. Page 191. Question 2. All are risk factors for gingival inflammation except one. What is the exception? Very good. What is the normal color of healthy gingiva? Now, this is where you want to look at the descriptions also. Now, we've talked salmon pink, salmon pink, salmon pink. Bluish red is more of a very stagnant inflammation, chronic inflammation. Red, beefy red is acute inflammation. Pale white is almost like that cyanotic. It's very fibrotic, as well as the whitish pink. When you see white involved, there's a lack of circulation. In an acute inflammation, the tissues exhibit a bluish red or pale white. In chronic inflammation, the tissues exhibit various shades of red. Oh, good grief. I can't keep my mouth shut for the life of me, can I? Okay, page 191. So these questions are coming from 191, my friends. Consistency refers to the firmness of underlying what? Connective tissue. What blank represents the total destruction and healing that occurs during the lifetime of the tooth? Now severity, because remember activity is there a 1 to 2 millimeter change from the last time or from a previous visit? So this is total destruction. The measurement of tooth mobility is recorded using which classification? Which is not a rationale for periodontal assessment. Okay, it does not determine the patient's willingness to change habit. Periodontal disease activity is characterized by what? Loss of connective tissue attachment and alveolar bone. Okay, so it would be ongoing. What is not an etiological factor for gingival recession? Okay, again, occlusal trauma alone has not been proven. Clinical attachment loss is determined by subtracting what from the probing depth or adding what to the probing depth. Okay, so clinical attachment level is determined by subtracting the gingival overgrowth from the probing depth, because you need to find where that CEJ is, and then you add the gingival recession. Okay, and I'm just moving forward here, folks. Chapter 17, radiographic assessment. Okay, again, this doesn't show us current disease status. It shows us past, what's gone on in the past. Some of the limitations are, this is a three-dimensional process, and we're looking at two planes. We can't see all around the tooth with traditional radiographs. So bone loss might not be seen because of some superimposition of the buccal and lingual bony plates. Soft tissue changes aren't seen. We can't see inflammation. We can't see gingival enlargement. We can't see recession. And so oftentimes we can't see the pockets. We don't know where the gum tissue is in relation to the bone. What's the purpose of radiographs? To identify any predisposing factors. We want to detect early to moderate bone changes where treatment may be able to preserve the dentition. And it's an approximate. We need to approximate the amount of bone loss and its location, but radiographs can help in evaluating the prognosis of the affected and the restorative needs for particular areas of the mouth. And again, it serves as a baseline so we know where the patient is today. Dentists dislike doing any type of examination on a patient without a radiograph, because you're only looking at part of the problem there. Okay, Parameters, kilovoltage, milliamperage, exposure time. You do need to know this. Kilovoltage, think about the volt. It determines the quality. How fast are those x-rays coming out? The penetration of the x-rays. Milliamperage, milli, number, all right? It's the quantity of the x-rays produced, and then the exposure time. We've got film types A through F. F is the fastest. The speed determines how much radiation the patient is needing. There are still questions on these silver halide crystals coming up on the boards. Paralleling versus bisecting technique. We use paralleling technique, and you have to have a holder for that. Bisecting, they do have bite blocks for those as well. So in paralleling, the film is placed, or the sensor is placed more towards the center of the mouth, versus bisecting is placed very close to the tooth. Bisecting distorts, so it's not recommended for looking at bone level. Bite wings are the best for looking at bone level. And if you can't get a bite wing, then it's a periapical. The benefits and limitations to radiographs, you know. Table 17.1, all you need to do is review that for the indications and limitations. Periapical radiographs, hopefully you have had some practice when you've had your clinicals, that you've been able to take some radiographs on your patients this semester. Bite wings, we do take vertical bite wings. You can also take anterior bite wings because, again, you're at that +10 degrees, so you are almost straight on, and it gives us the best level of bone. Panoramic radiography, it's great for the big picture and for looking for tumors. It's not great for periodontal disease or caries. Full mouth series. Hopefully, when you're in private practice, they will give you more than 5 minutes to take one. Depends on how nice the front desk is. Sometimes they want you to do a full mouth probing, full mouth series, do this, do that. They're ready for the Bell scope that day too, if you're doing the cancer screening with a special device, and they give you 40 minutes. It's like, this isn't going to happen. Not going to happen. But you want to take a look at those radiographs and look at that interdental septum, that crustal bone. Is it intact? Does it look like cotton candy? Now that crustal bone should be approximately 2 millimeters apical to the CEJ. So when you're looking at that template for that AAP classification, and it's telling you 2 to 3 millimeters of CAL, this and that, it's from that 2 millimeter apical of the CEJ mark. It's not from the CEJ. Okay, you're looking at the periodontal ligament space. A widened space might indicate occlusal problems. So you're looking at suprabony and infrabony bone loss. Infrabony pockets are associated with vertical bone loss. Bony defects may be seen on radiographs. Okay, but we don't know what the pockets are because we don't know where the soft tissue is. All we know is how much attachment loss. So the severity is classified as mild, moderate, severe, or advanced. If the crustal bone is more than 2 millimeters apical to the CEJ, then there's bone loss. So we're looking at the anatomy. We want about a 2-to-1 crown to root ratio. Okay, how much root is embedded in bone? Where is the bone in relation to the crown of the tooth because of the biological width? You're looking for periodontal changes, gingivitis, slight perio, moderate, severe. How much bone loss? Is it generalized or localized? You can have a generalized something and a localized something else. We, both of our campuses have digital radiography. There can be up to 90% reduction in radiation exposure. Digital subtraction radiography is where you're taking two images and you're superimposing them, looking for any changes. You've got your computed tomographic scans, which are your 3D scans, oftentimes used for implants these days. Periapical occlusal films can be taken post-implant. Pans can be taken post-implants, but the cross-sectional tomograms also aren't really good for implants because they're blurry, and this is really used more for research. So we're going into the CT scans, traditional and cone beam. Traditional CT is ideal for locating the amount and quality of the bone for implant placement above the mandibular canal. Where is that canal? We don't want to go puncturing that canal with a root form during an implant procedure. But cone beam CT, that takes images of both the maxillary and mandibular at the same time. And it has a lower radiation dose, but they require a lot of separate scans oftentimes, but it's like 400 to 600 different images that are then put together to make up one picture. And that shows us the quality of bone as well. Not just how much is from the top of the bone to the bottom, but it lets us know what the width of the bone is. All right, all the following are purposes of radiographs except doesn't show us the gingiva for the periodontal pockets. All right. Which statement is false in regards to the paralleling technique? Okay. Which statement is false? Okay, it is recommended. Bisecting is not recommended. Which of the following do bite wing radiographs show? Okay, good. What level is the normal crest of interproximal bone? Two millimeters, yes. Before bone loss is identified on a radiograph, ooh, I didn't go over this, approximately what percentage of loss of mineralization must occur? Do you remember that? 30 to 50%. Good job. All right, we're on our last chapter. Woohoo! Advances in detecting and monitoring periodontal diseases. So the standard for periodontal disease activity, as we stated, is 2 to 3 millimeters change in the attachment level. There are adjunctive tests that can be used to evaluate periodontal disease that's been developed, and they come in 3 groups: the gingival crevicular fluid assays, the microbial tests, and the genetic tests. So the supplemental diagnostic tests in perio, right? Box 18.1 gives you the tests. Table 18.1 has everything with the advantages and limitations, so do review that. You don't need to read the whole chapter if you understand Table 18.1. So the gingival crevicular fluid assays, as you know, the gingival crevicular fluid originates in the lamina propria, the connective tissue, and it's a good source of potential markers in periodontal disease markers. So it's formed when the fluids leak from the dilated blood vessels as a result of inflammation. It contains tissue breakdown products enzymes, inflammatory mediators, and other substances. So the gingival crevicular fluid is really easy to collect with paper strips. You just place them into the sulcus, and then you can do the test that way. There are host-derived enzymes. Okay, those are components of the gingival crevicular fluid, and some of these enzymes are associated with an increased risk of clinical attachment loss. So they can be used as markers for periodontal disease. And one of them is AST, aspartate aminotransferase. Now again, that ASE is an enzyme, and that AST is an intracellular enzyme that indicates cell death. And when present extracellularly, it may be a predictor for clinical attachment loss. One of the tests that I was doing in private practice was testing for collagenase. And that's a biomarker in periodontitis as well as cardiovascular disease. But I was putting these things into pus-filled pockets, and it was still coming negative with for collagenase. And I was on the phone talking to the developer of the test. I remember this was back in the early 90s, going, how can this be? Again, it was a difference between disease activity and inflammation that I wasn't making that connection with. So that's why I'm harping on it with you all, because I was a hygienist and still struggling. Prostaglandin E2 is associated with bone loss. It's a metabolite of arachidonic acid, and it's associated with the inflammatory effects. So you've got microbial testing that you can have cultures, microscopic techniques, or DNA, nucleic acid probe analysis. But bacterial biofilm is the primary cause, as you know, of the initiation and progression of inflammation. So we want to take a look to see what their bacteria is made of. So we've got certain culture techniques, and those are when pathogens are identified, as well as the antibiotic susceptibility is determined. So we're not doing this on everybody, right? But it may be useful for patients that don't respond to conventional treatment. It can only detect living bacteria. So it's very time sensitive. It's expensive. We can do it chairside, but it also determines what sensitivity these microbes have to certain antibiotics. So for the non-responsive patient, the culture might be the way to go. We've got microscopic techniques primarily used for patient education. They can't tell us the genus or species or the antibiotic susceptibility to antibiotics with these bugs, but it can let us kind of know what the activity, the amount and activity of the bacteria is. So we can use a phase contrast microscope, which is what private practice uses, and then the dark field, which is identifying the shape of things, is really used more in science and research. But phase contrast microscope categorizes bacteria based on the motility. Is it a spirochete? Is it a rod? Right? And it lets the patient know. You can show the patient and they can see the amount of bacteria. They can see it jumping around. And they're going, ooh, that really is living underneath my gum tissues, isn't it? The DNA, the nucleic acid probe analysis, identifies DNA sequences. Okay, DNA, all living organisms have DNA. It's good for screening purposes. It is very sensitive to specific pathogens, and DNA is very stable. So we can send this off to a lab, and we can have some rapid identification with it. So it can identify up to 11 pathogens. With it being the big guns, the P. gingivalis, which is very strongly associated with all periodontal disease, but we also have the AA and the P. intermedia and the other things, the T. denticola, that are associated with more of the advanced periodontal disease. So the DNA of each species is unique. It's expensive. We don't use it routinely, but it is used for, again, the patients that aren't responding. Some periodontists or oral surgeons recommend doing this prior to implant placement as well. There's immunological assays. ELISA is one of them, and that's based on specific binding of an antibody, to an antigen on the surface of a periodontal pathogen. It's very expensive. ELISA is just used in research. There's enzyme-based assays, and that's based on the ability to screen for the presence of an enzyme unique to one or more bacterial species. And one of them is BANA testing. And BANA is something I did in private practice, as well as the collagenase. BANA will let you know if you have one of the three red complex, or two of the three, or three, I mean, it lets you know red complex, all right? And it depends on the color. It's kind of like a pH test, okay? What color of blue is it will let you know how much of these red complex is underneath the gum tissue. We've got our genetic assays. Remember that interleukin-1 genotype, right? If you are you're more susceptible if you have that interleukin-1 genotype. And interleukin-1 is a cytokine secreted by inflammatory cells as a response to inflammation. Does not mean you're going to get periodontal disease, but it means you are predisposed to it. You're at a risk for, okay? Again, not everybody needs to be tested for it, but I understand that the DNA testing that's out there can also tell you whether or not you are an interleukin-1 genotype, depending on which DNA test you sign up for. Which of the following substances is not an inflammatory mediator found in gingival crevicular fluid? T lymphocytes. Now, only because I kind of talked about all the other ones, so that would have been a good guess. Which of the following is an intracellular enzyme that indicates cell death when found extracellular? AST. Which of the following is an enzyme that breaks down collagen and is a biomarker in periodontitis as well as cardiovascular disease? Yes, collagenase. Which testing technique requires that bacteria must be alive on reaching the laboratory? The culture. Remember, the DNA doesn't need to be alive. Which one of the following host cells synthesizes and releases glucuronidase and elastase? That was not in my review either. Very good, guys. Oh my gosh, I'm impressed. Which microscopic technique categorizes bacteria by motility? Not by type, but by mobility. And it's the phase contrast microscope. The dark field will give you whether it's a rod or a spirochete, that type of thing. Which microscopic technique, okay, identifies bacteria by morphology or shape? Dark field, yeah, I gave that one away, didn't I? All of the following statements are correct concerning the use of diagnostic methods except one. Which is the exception? Okay, they predict periodontal breakdown. Which of the following options describes a key advantage to using DNA as a biochemical marker in the identification of periodontal pathogens. They don't have to be living on reaching the lab, okay, because they it was between B and C. Okay, so then you have to just start going, okay. So that is, that's it. You did it. I don't know what time it is. Okay, I went over time too. Is there anything you would like to discuss?